From Microbe TV, this is TWiP, This Week in Parasitism. Episode 167, recorded on February 26, 2019. I'm Vincent Racaniello, and joining me here in New York City, Dickson, Despommier.
Hello there, Vincent.
And Daniel Griffin.
Hello, everybody.
Hello there, Daniel.
Daniel's right here. You know what the title of the last episode?
Tell us.
From remote locations, because we were all remote.
We were Skyping. That's
and
true.
Today we are all local.
That's
right.
Great stuff.
That's
Good
right.
to see you, Daniel. Daniel has a bow tie on.
Yes.
He does.
Does it have viruses on it?
Something on
You
it.
know, this is my prion. This is my Creutzfeldt-Jakob disease bow tie today. Yes.
Lord.
Yes.
We need a picture of you guys, right?
No matter what you do, you can't get rid of that one.
You know, the only problem is as we scrunch in for a photo, Dickson is going to spill his coffee on me, and it's full of milk and sugar. So.
All right, you just have to move over so we can see your bow tie. There you go. That could be the episode image.
That's right.
Okay.
All right, so we are here to start with our case from last time. Daniel, remind me.
Sure. Well, I will say the reason I am dressed this way is I came straight from the hospital.
Mm-hmm.
I will probably have to go straight back. I already see my phone ringing, people trying to call me about patients. So,
Of course.
Periodically during the show, I'll just, cut out and answer consults. But let me actually remind everyone and acquaint people tuning in newly to the case from our last TWiP. And actually, this was, apropos, a consult from a gastroenterologist who called me and said, I've got this woman I was hoping you could give me some advice on. It is a 61-year-old woman, and she had gone on this, as we said, it was a girls' trip. It was a bunch of similarly aged women friends who went to Thailand and went to Cambodia. They went for a few weeks. And while there, she developed diarrhea. She took her azithromycin as recommended by her travel provider before she went. She did the 3 days, 500 milligrams, once, twice, third day. But the diarrhea continued. She got back in the States. The diarrhea was still going. So at this point, it had been going on for a few weeks, and she was starting to develop some left lower abdominal pain. She felt bloated, gassy, reported loose stools. They were sticky and foul smelling. Got a little more information. I don't know if Vincent asked about this, but not sexually active in the sort of immediate time before this happened. But we did bring up, that was a good question, Vincent. We said she was not restrictive in what she ate, but she was trying to be careful as far as drinking bottled water, and she didn't eat any raw items.
All right. We have a good story about bottled water coming up.
Oh, good.
Excited.
All right. Eric writes, "Hi there, TWiP advisors. After hearing this week's case of the week, I can really only think of one thing that could be the causative agent of the woman's symptoms. Ordinarily, I would try to provide other possible infections, but when I hear the word sticky, foul-smelling, loose stool, I can think of no other parasitic infection than Giardia lamblia. Giardia has a global distribution, including Thailand and Cambodia. We generally think of giardiasis occurring as the result of drinking contaminated water while out in the wilderness hiking or camping. However, this doesn't seem to have been the case with the woman who visited Thailand, as she reports drinking bottled water. But Giardia can also be contracted by consuming food items that have been in contact with contaminated water. For example, a salad that was rinsed with water containing the parasite. Giardia is often treated with metronidazole, Flagyl, or tinidazole. Regards, Eric."
Great.
Dickson.
Blair writes, "Dear Vincent, Dickson, and Daniel, I believe that this 61-year-old lady is suffering from giardiasis, secondary to the parasite Giardia lamblia. She had steatorrhea and is bloated and gassy due to fat malabsorption in her small intestine, where the parasites like to reside. It is notoriously tricky to confirm the diagnosis. Identifying the cysts or trophozoites in stool can be hard, as shedding is irregular and often requires several stool specimens taken on different days to increase the diagnostic yield. As patients are usually being managed in the community, it is laborious to get them to come back to submit stool specimens for analysis day after day. So at our center, we do a PCR test to increase sensitivity if microscopy is negative. The other way to make the diagnosis is by getting a duodenal aspirate or biopsy, although these are invasive tests and hence generally reserved for specific situations. We have a low threshold for empirical treatment with tinidazole, 2 grams, single dose, if the history seems classical, as in this case, but it is always nice to confirm the diagnosis. An alternative would be metronidazole. It is important to remember to let the patient know to avoid alcohol for a few days with either treatment. It can and is sexually transmitted via the fecal-oral route, hence important to consider. Ask about sexual practices. I'll leave it at that. First, I got into listening to your podcasts while studying for the diploma in tropical medicine and hygiene a couple of years ago and continue to enjoy them just as much today. Keep up the good work. Best wishes, Blair.
So I think it was parasitic podcast, and I'm trying to try to decide if it was parasitic as a descriptive relative to contact,
right.
or descriptive as a quality about our podcast.
Mm-hmm.
I have a short one here from Adam. Adam writes, "Dear Vincent, Dickson, and Daniel, my guess for the case in TWiP 166 is Giardia, something I personally have had on a few occasions when traveling in Nepal.
That's a good place to go.
Diagnosis is by microscopy or PCR of the feces. Treatment is tinidazole or metronidazole. Best regards, Adam from Halmstad, Sweden."
I should take the next one, Daniel. As
Right.
well.
Certainly. Nathan writes, "Hello, TWiP experts. I teach a junior-level parasitology course at UMass Dartmouth in the Medical Lab Science program. This year, we adopted PD6 as our textbook.
Nice.
The students were very happy to see that there is a free ebook version available. The 25 students in the course listened to the case study this week and wanted to give it a shot. We have covered everything except for trematodes and cestodes so far. Based upon the symptoms, the students think this case is consistent with Giardia duodenalis infection. The patient reported foul-smelling, sticky diarrhea as exposed to the good-smelling diarrhea with flatulence, pain, and bloating. The information is very consistent with the clinical disease description of Giardia duodenalis on page 15 of PD6. The acute diarrhea of giardiasis is classically described as foul-smelling with flatulence, nausea, weight loss, and abdominal cramps with bloating. Untreated, this type of diarrhea may last weeks or months. She likely became infected when consuming food or drink contaminated with the infectious cysts. The organism can be diagnosed via direct microscopy. The students reported that this organism is often difficult to find microscopically because fecal smears can be messy. Nats and ELISA are alternative testing options.
They are by definition messy.
If this patient is in fact infected with Giardia, the treatment is metronidazole for 1 week. Thanks again for producing this podcast and inspiring the next generation of parasitologists. If we win the book, please respin, as we are happy with the digital version. Okay.
All right. Next one is Kevin. Diarrhea word of the day related to our case in the most tangential way possible. Leantary, a form of diarrhea in which the food passes through the bowels partially or wholly undigested. An instance or kind of this. A lexicon of diarrhea terms appears in the endnotes. Case, diarrhea in a 61-year-old female traveler to Thailand and Cambodia. Diarrhea that has persisted several weeks. Stool is described as bulky, sticky, and foul. The word bulky is one that I've heard for years in reference to stool, where it is invariably associated with the malabsorption syndrome. After considering this case, I realized that the precise definition of bulky in reference to stool completely eluded me. I was reminded of the Karl Kraus quotation, quote, "The closer the look one takes at a word, the greater the distance from which it looks back." I usually considered bulky to mean big and chunky. Bodybuilders were bulked up. A large book was bulky. Right. I always associated bulky with something solid, which gives rise to the rub. How can diarrhea, a liquid or semi-solid, be bulky? To clarify this matter, the Oxford English Dictionary assisted. The definition of bulky, among others, was voluminous. Stool morphology is characterized in the Bristol stool chart, see the reference in the endnotes, where the term bulky is unmentioned, but their spectrum of stool character ranges from nuts to gravy. Forgive my food metaphors.
Well, it used to be food.
Finally, on a practical level, I suspect that if you asked someone if they were having bulky stools, you would at best receive a puzzled expression and at worst a clip in the ear hole. The many varieties of traveler's diarrhea, their relative etiologies, incidences, and geographies are referenced below. Of course, bacteria and viruses form the bulk of the cases. Relevant to us are protozoa and helminths. Traveler's diarrhea survey studies and our patients' clinical presentation with bloating and malabsorption type diarrhea strongly suggest giardiasis. Other considerations are cryptosporidium, immunocompromised at higher risk, diarrhea described as watery in PD6, Cyclospora cayetanensis, Entamoeba microsporidia, closely related to fungi but behave like intestinal protozoa, primarily a disease of the immunosuppressed, and Cystoisospora belli, immunocompromised, can manifest as malabsorption syndrome. Helminths such as Strongyloides, Ascaris, hookworm, and Trichuris should be kept in mind, but our patient's clinical presentation is not consistent with worms. Co-infection with multiple parasites must always be kept in mind, as studies and surveys provide ample evidence for this. Diagnosis of giardiasis traditionally was with microscopic examination of fresh stool and occasionally microscopy of duodenal aspirates. In the 80s, an awkward intestinal sampling technique was used, formerly named the Entero test, informally called the string test, which PD6 charitably eulogizes with the entry now relegated to a place in history. Individual PCR testing is available, but even this modern technique is being replaced by a variety of nucleic acid tests, such as the Luminex Tag G1 GI pathogen panel, which tests 19 enteric pathogens, including 3 protozoa. The BioFire Film Array GI panel has 22 targets and a potential 1-hour turnaround time. Other gene array panels are the TACMAN Array Card and the C-Gene Allplex GI panel. These tests have very impressive sensitivities, specificities, and turnaround times between 1 and 4 hours. Multiple internet sources list the price of about $150 for one GI panel. This price quote requires further research, however, as it sounds too good to be true. Treatment is succinctly outlined in PD6 with initial treatment metronidazole or tinidazole. Refractory disease, resistant organisms, and recurrent disease are fully discussed in the text. Recurrence or persistence of symptoms post-treatment should always raise the possibility of post-infectious irritable bowel syndrome. Patient should be offered HIV testing if it has never been done. Her overall prognosis should be excellent. Who knows where she picked up the offender? But as an old parasitology professor used to intone, quoting perhaps apocryphally the famous Rockefeller Institute parasitologist Norman R. Stoll, the path from the anus to the mouth is all too short. Thanking the TWiP panel for their time, dedication, humor, etc.
Must tell you that Norman Stoll was a friend of mine. While I was at Rockefeller, he was winding down his career, and I had the pleasure of his company for a year and a half. And he was an extremely erudite, well-read man of letters, as you would call it, and told about the history of the hookworm commission from the Rockefeller days. And so that's something that's been coming up again and again when we talk about the discovery of hookworm, etc.
The path of the anus to the mouth is not really short, but it's from the anus to the urinary tract is very short.
No, what he meant was that...
Yeah, I know what he meant, but anatomically it is not short.
No, he was trying to be funny in this case.
But the other is a problem, right? The way animals have been designed is, and that's why we have urinary tract infections. Right?
Very true.
So Kevin, as usual, provides a large reference endnote and a terminal curiosity. Lots of references for all the things that he says here. Wow. I want to move through these, which you should check out in the show notes. There's studies and so forth. Terminal curiosities talks about bulky, and he says, in the course of reading background material, I came across this sentence. He had a history of periumbilical colic-like abdominal pain, push, tenesmus, meteorism, audible borborygmy, semi-liquid to pasty feces, and 5 to 8 explosive bowel movements a day. Since some of these terms might be obscure to some listeners, I have constructed a crude lexicon diarrhea. He talks about...
This is the very thing that Norman Stoll would have loved. He would have talked with this gentleman for two or 3 days, I'm sure.
Loose. I often heard this loose stools. Exactly. I've never seen a proper definition. Push, He doesn't know. Impulse or urge. Explosive. Meteorism. Borborygmy. The term borborygmy is applied to the sound produced by displacement of gases within the abdomen.
Darn.
Tormina, a golden oldie. Acute griping or ringing pains in the bowels. Gripes.
Tenesmus.
Grips or gripes. Tenesmus. Leontary. That's our original word.
Yeah.
There. Wow. Thank you, Kevin. And I've forgotten who's next.
I am.
You are Dickson.
I am.
You know, we should, in one of our future editions, maybe we'll say 8, we should have a whole glossary. And we should have importantly defined, but then we should throw little fun ones in.
Well, you know, we could make it into an archaea, just like you do for bacteria.
You can go through Kevin's emails and find.
Yeah, Kevin, we might grab a few of those just to let you know. We won't credit you either.
No, we won't. Amiche writes, Dear Tremendous Trio, though with way less confidence than last time, I think I have another guess for the mystery case. The GI symptoms can indicate anything from virus to worms, but long symptomatic period suggests constant reinfection together with the antibacterial failed treatment. A parasitic worm seems more plausible. The fact that the patient claims to avoid raw food and local water suggests infection route other than oral. Combined with the patient travel history, my guess is Strongyloides stercoralis. Also, I think Professor Despommier already mentioned that he and his wife had it once in previous episodes. The larvae can be identified in stool sample, and as for the treatment, PD 6th edition suggests albendazole and ivermectin. Thank you for another interesting episode. We will return to this email later.
I was just thinking, you want to be careful, Dickson, of suggesting that you and your wife had one of the maladies, because it may turn out to be a malady that you don't want to.
We're going to correct the malady that we actually
the malady lingers?
Malady lingers on? I've heard that one.
Harry Ginsberg used to say that.
That's a quote, that's a malaprop from a song. The melody lingers on.
Right, but he meant...
I know what he meant.
Malady.
Exactly, I know what he meant. Just like Norman Stoll meant that. Well, that's okay.
Yeah, Daniel.
Alexander writes, Hi all. It's been a long time since submitting a guest for a case. I've been busy with trying to get used to the change of life in university from college. I think the woman who is traveling to Thailand and Cambodia might have giardiasis from Giardia lamblia. The symptoms seem to line up with abdominal pain, flatulence, and loose and foul-smelling stools. Mm-hmm. According to Dr. Google, symptoms tend to appear a few weeks after exposure. As she drank bottled water, I'm going to assume that the exposure most likely came from the food that she ate. Was she the only one of the party that became ill? If so, she might be immunocompromised or hopefully just really unlucky. PD 6th edition states that microscopy is still the definitive diagnosis, but ELISAs, and NATs are available depending on a lab's resources. If it is G. lamblia, PD 6th edition says that the nitroimidazoles are used to treat it. I'll leave it to the professionals to know which one is the best. I have gotten lucky before and got the hardcover of PD 6th edition. However, I wanted to see if my old college might want it, but being 100 miles away from there and only returning home on the holidays hasn't allowed me to bring it over. So while I would like a copy for myself, please remove me from the drawings so that other people may have a greater chance. Thank you, Alexander Islas.
Caitlin writes, Dear upper class TWiPs. So, do you get that?
You know what that's from, don't you?
No, I have no idea.
It's from Monty Python.
I never watch Monty
Python. You must tell me.
No, there was an episode called Upper Class Twits.
Twits?
So this is a takeoff.
Okay. Well, I was inspired by Twit, This Week in Tech.
Right.
So that's perfect. The lady with sticky, foul-smelling diarrhea, abdominal cramps, and bloating appears to have a textbook case of giardiasis caused by Giardia lamblia. All of the symptoms seem to fit along with the timeline. This beastie is transmitted fecally orally through contaminated water. Although the patient was careful to avoid potential sources of contamination, Giardia gets everywhere in endemic areas.
This is true.
Other possibilities: Cryptosporidium, but she's not immunocompromised. Cystoisospora is capable of causing prolonged diarrhea. However, it is unlikely to make a previously healthy patient so ill, mainly serious disease in AIDS patient. It was noted that she is not sexually active. She may have been earlier or might have been infected with HIV some other way, but it's highly improbable that this wouldn't have been detected earlier. Cyclospora cayetanensis can cause diarrhea 2 to 3 weeks. We're at least on the upper end of that with several weeks. What's more causes rotary diarrhea, so it neither fits the symptoms nor the timeline. Strongyloides can produce diarrhea lasting up to 6 weeks in about a quarter of symptomatic patients, but again, the diarrhea is supposed to alternate with constipation. Capillaria philippinensis produces protracted diarrhea and malabsorption of fats, which suggests it could result in the greasy, sticky stools in this case, but in addition to being not quite the right part of Asia, it's caught by eating raw, undercooked seafood, which the patient avoided. The infection is not 100% certain to be Giardia, but given that it is absurdly common and causes noticeably sticky, oily, foul-smelling diarrhea, steatorrhea, it is by far the likeliest in this case. It can be detected by examining the stool for trophozoites or cysts, or if we're going to be more modern, antibody tests. The patient should be treated with metronidazole or tinidazole. If we win the book, please donate it to a university. Perhaps the maths department would appreciate it. This letter is a tale of 2 continents brought to you by Carrie from Newcastle upon Tyne, England, and Caitlin of Seattle.
Cool.
Love these international collaborations.
We've had letters from them before.
So why would a math department want our book?
I think it's a joke.
Okay.
Because they probably wouldn't even...
It reminds me of a horrible joke, and I'll tell it to you. Have you heard about the constipated mathematician? He worked it out with a pencil.
Oh, Dickson.
Dickson. This is a family show.
The constipated mathematician is a good title for the episode.
The constipated mathematician.
Dickson, you're next.
I am? Okay. Lauren writes, "Hello, TWiP. In response to the recent consult from gastroenterologist regarding 61-year-old woman on trip to Thailand, Cambodia for a few weeks, here is my differential. Entamoeba histolytica, Cryptosporidium parvum, and Giardia lamblia. These are my usual suspects for diarrhea. Cryptosporidium parvum is notably watery and quite profuse. E. histolytica, when it is clinical, usually exhibits with a fever as well as a heme-positive stool. Giardia checks a lot of the boxes for diarrhea, bloated, gaseous, loose stools, sticky and foul-smelling, plus active stage in the small intestine, which so happens to be in the lower left side of the abdomen. So I'll have to go with my gut feeling, in quotes. Sorry, couldn't help it. I suggest to you diagnosis of giardiasis from the protozoa Giardia lamblia. Here are some potential ways to confirm the diagnosis. Stool, ova, and parasites test, antigen capture ELISA from stool sample. Maybe if not, she is immunocompromised, since it would not be effective. Or a nucleic acid amplification test, NATS. Treatment. Giardia usually clears up on its own in a couple of weeks, but in some individuals it may persist if their immune system isn't up to snuff or has difficulty dealing with Giardia. Preferred drug options are metronidazole. She gives a dose. Alternative drugs are paromomycin, furazolidone, quinacrine, and quinacrine, that's an oldie, and albendazole. These would also be effective against other protozoans. It may be one of those newfangled resistant varieties of Giardia, but with a different class of antimicrobial therapy or a longer course of oral agent. If some refractory cases, combination antimicrobial therapy may be necessary. From the Parasites Without Borders video on Giardia. Mm-hmm. That sounds like a familiar reference. Azithromycin may not have been effective because it is used for bacterial infections, i.e. Vibrio cholera, dysentery, yet I also saw toxo in that list, which is a protozoan. So, sorry for the brevity of my email and the tardiness of my last. Thank you for everybody's time and effort on TWiP. P.S. For us non-med students, what is the symptomatology in the quadrantal description called the organ involvement based off the area of discomfort? It would be beneficial to know what that is called in diagnosing, so I can know what organs are being affected. Thanks.
Daniel, you'll have to explain that last
Sure. Certainly. There is a short book. It's less than 100 pages. It's called Cope's Diagnosis of the Acute Abdomen. Mm-hmm. And it was written about 100 years ago. And it's still a great book to this day because it's so straightforward. And it's this idea that if you have pain in a certain area of your abdomen. So you break it down into 4 zones or quadrants. And then you ask if you have pain in your left lower abdomen, in your right lower abdomen, in your right upper abdomen. You just ask, well, what organs are there? And then it leads you to think. If it's, let's say, it starts as a periumbilical pain and then moves into the right lower quadrant, that's your classical appendicitis description. If it's right upper quadrant, we start thinking of gallbladder, liver.
Or an amoebic abscess.
Well, liver, right?
Yeah, absolutely.
If it's left lower quadrant, we start thinking of the sigmoid or the small intestine.
Okay.
If it's left upper quadrant, we start thinking of spleen, maybe stomach, transverse,
and these
upper part.
directions are in the handedness of the patient.
They're the patient's directions, not yours.
Got it.
So, which is actually important. Like your mind switches, I think,
Yeah.
when you start practicing medicine.
Okay.
So when we think about left lower quadrant, and it is worth a read for anyone. It's a short little book. It's a classic of medicine. Cope's diagnosis of the acute abdomen.
So in this case, where was the discomfort?
It was left lower abdomen. So what are we thinking? We're thinking sigmoid, descending. We're thinking small intestines.
Right.
Now, if you have tumors down there, they could be anywhere, right?
It's interesting. They taught us, among many things that were not true during medical school, that the majority of tumors, of colonic tumors, were within the reach of your finger, which is why you should always do a rectal exam. Now, my finger is about 4 inches long. They also taught us in the same breath that a large percentage of cancers were now on the right side. Now, the right side is about 4 feet away from the rectum. I'm thinking 4 feet, not 4.
We're not talking about 4 inches here.
It's a long finger.
We're talking about a small fly rod's length.
True. So over time, over the last 100 years, 50 years probably, the frequency of where colon cancers form has been shifting away from the left, sort of the sigmoid descending colon, over to the right-sided ascending colon.
Huh.
So
Is that because we're doing colonoscopies? We never saw them before?
I don't know if we have a good explanation for why.
Because previously they just did those sigmoidoscopies, right?
Exactly. The one of the earlier screening methods was the sigmoidoscopy, and the sigmoidoscopy would come up, look through the sigmoid, and would get up to just about the splenic flexure, which is the upper left quadrant where the colon. We're going backwards now, right? Where it turns, so it's either turning to go down or turning to go horizontal if you're coming up. Now, I think we've pushed a lot towards full colonoscopies, which done properly goes up through the sigmoid, up through the ascending, transverse colon comes all the way down, and you should visualize the ileum so that you've seen the cecum, the whole colon.
Yeah. And even in the old days, it was a rigid sigmoidoscope, right? The early one.
Yeah, the original, I think we've talked about the something stallion. So it was the original. It was a gentleman here in New York City, I believe, who invented it. But it was a straight scope with a mirror system that would pass up, and you would sort of do this twisting, pushing, pulling, and you'd sort of stacking the colon on it as you went up to try to visualize, but you could not get very far.
Yeah. Wow.
Right. The one I like the best is the one you swallow. It's a little camera, and it goes all the way down through your gut tract. Capsule endoscopy. And it gives you the entire gut tract. That's a remarkable device.
But that's not widely used yet.
No, but I think I would like that better than the others.
Yeah, but the problem with that is that it might miss something, right?
Yeah, we don't use that much for colon cancer screening. We use that more for small bowel pathology, so the capsule endoscopy. Okay. But no, nowadays the flexible colon, colonoscope, and people are usually sedated.
Yeah, sure.
Pleasantly so.
I've had many. Both of my parents died of colon cancer, so I have to have one a week.
One a week.
Just kidding. All right, last one is from Trudy. Daniel, why don't you take that?
Trudy, dear TWiPers, I believe the 61-year-old woman is infected with Giardia lamblia. The parasite is acquired through the fecal-oral route, most often by drinking contaminated water. It is my understanding that she only drank bottled water during her travels. But have any of you seen Slumdog Millionaire? What a great movie.
Yeah,
there's a scene at the beginning where retainers of bottled water are refilled and resealed using bottles with tap water.
That's very common.
This is in India. But I think it's safe to assume that it would happen in other third world countries as well. Diagnosis would require analysis of a stool specimen by microscopy, ELISA techniques, or nucleic acid amplification. For treatment, the patient would be given a nitroimidazole, metronidazole, or tinidazole. I already own a signed copy of Parasitic Diseases, so no need to enter me in the drawing. Thank you. However, I still need to come back to the TWiP studio so Dickson can sign my copy of A West Nile Story. Hopefully soon. Thanks again, and best regards, Trudy.
Right. There we have it. All of them.
There we have it. So we return to the one I read before that had a reference to the fact that my wife and I both caught an infection.
And you want to claim it's not strongyloides.
I do want to claim it's not strongyloides, and I also want to claim that it wasn't me. It was just my wife.
Oh, so one person gets strongyloides.
So she had Giardia. She had Giardia.
Yeah.
Your wife had Giardia.
She had Giardia.
Did you as well?
No, did not. So either I was lucky or she ingested something that that would be luck anyway, but we both ate essentially the same food and drank the same water, so...
Well, all those years of working with it, you became immune.
No, I never worked with Giardia. But I certainly, as a technician, diagnosed a lot of it. There was a lot of it, even in the old days, as they would say.
Didn't you make slides with stool samples and look at?
No.
So you could have gotten infected.
Student collection, but they were all preserved. Those were
preserved.
All
okay.
Oh yes. Oh, absolutely.
You didn't work with any fresh feces?
Well, if we could, we did, but it was hard to get. I mean, it was.
The name fresh is just. It just seems a malaprop for feces. Because feces have. By the time they come out, they've been incubating for a while.
This is all true, but sometimes it comes out really fast, as in the case of this one. So you have frequent diarrheal episodes here.
So, Daniel, almost everyone got Giardia.
They did.
And I must admit that when I first heard this, it was just the description of the diarrhea that led me to think of Giardia.
I would agree.
As well as the conditions of infection and so forth. You would agree as well, Dickson?
Of course. I mean, this is classic Giardia diarrhea. And it happened fast. The thing is that if it's a worm other than strongyloides, it would take 3 to 4 months for these worms to mature enough so that you could make a diagnosis. Even if they were causing the diarrhea, they wouldn't be able to make the diagnosis because the stages that you would detect in the stool wouldn't be passed until then. Whereas Giardia is like a week later, you're passing lots of trophozoites and cysts. So I think this would be a fairly easy diagnosis, especially with the gnats.
What do you think about that? Should we do it gnats, or should we just say treat them? It sounds so convincing. Let's treat them.
There's a danger here because they treated her with azithromycin, but it didn't work.
Right, and that's actually I think that's a good point. When I was in practice in Colorado, we would see Giardia on such a regular basis that we actually got in the habit of, when we got a story as compelling as this. Right. And then actually, I think someone actually brought this up, because in a lot of people's mind, beaver fever, it's the person was camping, they drank untreated stream water, and now they come back and they come to see their doctor with this story. Now, in this case, the person underwent gnat testing, which truly does, it's about $150. That's that isn't the cost of the test. That's the charge, right? So there's a profit built in. Somebody's making a profit there.
That's right. Exactly.
We live in our capitalist society.
We do.
But boy, a test that's worth its $150.
Is this a panel, or is it just a single?
In this case, so the gnats are usually, and I think someone went through these. This was the BioFire. Which has about 22 different pathogens, and has a 1 hour turnaround time. And it's a machine, maybe 2 feet by 2 feet. Some of the docs have them in their offices. This was actually sent out to a reference lab. But the feces gets put into a cartridge. It pops in, a few buttons are pushed. Wow. An hour later, it tells you what they have or do not have.
That's amazing.
BioFire. I was once in Atlanta. I was visiting Emory. I was sitting in the hotel having breakfast, and a guy walked up to me. He said, "Are you Vincent Racaniello?" And I said, "Yes." He said, "I work at BioFire. I listen to your podcast."
I'll be darned.
How about that?
Oh, that is nice.
Yeah, BioFire. That's pretty cool. These panels. So it came up positive for Giardia, Daniel?
Came up positive for Giardia.
Wow.
And nothing else, you might add.
Nothing. And that's also nice, too. And I think we've had a case before where we thought, oh, this is a great story and it's compelling. And then you find out that they have more than one thing, which, Occam was not a physician, as I like to point out. Sometimes people have
dropped
more
out of medical
than...
school at an early age.
So.
I think I must have mentioned this one other time on this show, but I'll do it again because it's worth repeating. A mother and daughter took a trip to Mexico, and they both came back about 3 weeks later, and they both had diarrhea. Mm-hmm. And they had visited places like Acapulco and other coastal cities. And the person who diagnosed it on symptoms and travel history, and assumed that they both had amoebiasis, and treated them both for Entamoeba histolytica. And indeed, one of them got better, and that was the mother, who actually did have amoebiasis, but the daughter did not. What did she have? She had Salmonella typhi, which was a much more dangerous parasite in some respects. And she called me about 3 weeks after the incident of her mother being treated and getting better, and she claimed she was almost dead, but of course she wasn't, but she was approaching that zone. And wanted a recommendation, and I gave her one, and she got better almost instantly after they started treatment with the proper antibiotic. So it can be two different things, and both people were unlucky, and they picked up different pathogens from the same trip, eating the same food, same water. It can happen.
No, it's a good point, and I actually was thinking about this issue that we present these diagnoses. It's so compelling. Well, we obviously know what this is. Right. But the reason we order the net is we don't. We don't obviously know. This is a very compelling, I like to use the word compelling.
Sure.
This is a very compelling presentation. But you do want to confirm because you don't want to miss something.
You bet.
You don't want to treat people as this one was treated unnecessarily. Yep. Here's some Azithra. Go ahead and take this when you think you need it, which is reasonable for traveler's diarrhea, but not going to do anything for your Giardia.
Nope.
Might actually be a nice treatment for your Salmonella, actually. Interesting enough. But yeah, so I think that in a lot of circumstances, we talk about limited resources, meaning you do not have diagnostics. But one of the great things as a clinician is to have diagnostics. So you're constantly getting correction. Not only are you getting correction so that you become a better clinician, but you're getting correction so that you are treating what your patients have, not what you think they might have with whatever margin of error.
We're going to get to that when we get to our paper, because I have some questions for you on that. But
that's excellent.
Very interesting.
I tell my kids, they come, I think I've brought this up, they come back with like a 90% on a test and they're so proud. I'm like, oh my gosh, if that was my performance at work, I'd be in trouble. Wouldn't want to have been that 10th patient that you just got wrong. No, I'm only half joking there. I joke with them a little bit about it, but no, in medicine, you want to get that higher level if you can. And this is an example where it was a very compelling story. But then what really clinched it is we got the confirmation. And in this case, it was interesting. Like you jumped over this, Dickson, where and she mentioned some dosages for the flagell, which is funny because the gastroenterologist, I told him, I said, well, we usually recommend 250 milligrams POTID, so by mouth 3 times a day. And there was sort of a pause. And I said, but if you've never prescribed 250 and you prescribe 500 3 times a day, that's not going to be the end of the world.
No.
But the funny thing is that, you get comfortable with a certain, but we point out, and in our new edition, we'll have a clinical appendix where we have the specific dosages, duration, frequency, and it's a little bit lower for this disease than the dose of metronidazole is for others,
like amoebiasis,
where you'll use a higher dose.
Exactly.
So you had originally said the sexually activity question was relevant because this can be fecal orally spread, right?
Exactly.
But in this
case, an
case,
interesting issue. So Dickson, do you want to talk a little bit about, because how does that work, right? We're talking about cysts being ingested and going in.
Well, you can have anal intercourse and then fellatio, okay, if you want the proper terms for those. And if you do that, and a lot of people do, that's an easy way of transmitting this from one person to the next. So.
Or you
but the cysts are
you
coming
do
out.
There
are other things besides with the sequence you just said.
Exactly. When you need more than 2 partners, so that's the point. If you look at this way, the person who would be getting it is the person who had it.
You have to have 2 because one can't get it. from themselves.
You can't. So you have to have a contaminated field.
Yeah. Once you've got
as
it,
the physician would
But
say.
they're the kids who put the worms from their anus to their mouth at night, right?
They scratch, and they're
Yeah,
not doing it on purpose.
that's different.
That's true. That is different.
But they persistently infect themselves.
That's
because
correct.
of
They
that, right?
auto-infect it. That's exactly right.
Okay. And in
Could
this
probably
case,
do that here too, but
in this case, there was no evidence that she was sexually active.
No, there
Okay.
wasn't.
Okay.
But I guess ultimately, that's where is it coming from? The cysts are coming out in someone's feces,
Yeah.
and then they're getting into her mouth.
food handlers are the common source for these infections when you travel, and people who make the salads or
Yeah.
who claim to be cleaning the glasses and don't always do that. Or employees must wash hands before leaving restroom. That sign is rarely observed because of the high volume trade during lunch or breakfast or whatever. So you can get into
Yeah,
trouble
what was
with
it? My obnoxious friend asked the management, that's just for employees, right? I don't have to do that. It's like, yes, you do have to do that too.
Exactly right.
But no, it's a very simple life cycle.
It is.
The cysts are coming out, the cysts are being ingested,
That's right.
initiating the infection, and then getting cysts again. And
Right.
All
I
right.
mean, even though we've had this once before in our cases, this is really worth bringing up again because periodically people have to be reminded of this.
And Giardia, hopefully what's helpful here is I think we had a case before, I don't know what our last one was, but you can get Giardia just going up in the mountains. You can get it in a ski town. Aspen has outbreaks, a lot of the Colorado
Or
towns.
in a daycare center for
In a
children.
daycare center.
in all kinds of places. So
In New York City. But it's also something, so it's one of those parasites that does not respect borders.
none. Zero.
In our country, it's in everyone's country. It's quite
That's
prevalent.
right. That's right.
So the patient did well, right?
The patient did fine,
Fine.
fortunately.
She might have lost a little weight along the way, too.
Never a bad thing.
Never a bad thing. But this is not a good way to lose it because there's something called a rebound effect. After you're cured, your appetite returns and you tend to miss those foods that used to give you problems like fatty foods and, high caloric foods. You go right for those. And the next thing you know, you're over the weight that you were before you had.
Actually, that brings up a good thing, which I should throw in for the clinicians in the audience who might be using this to approach patients. And I've seen this happen where someone's come back with, let's say, Giardia or traveler's diarrhea, and you treat them. And one of the things people forget to mention is you want to be a little careful as you reintroduce your normal diet, because a lot of these will cause a loss of the enzymes on the terminal villi in the GI tract. So for a little while, people will have a temporary lactose intolerance, a temporary food intolerance.
Sure.
So if they think, oh, now I'm on my medicine, I'm all better, and then they go and they have their enchilada with cheese on top.
Exactly.
And they call you on the phone like, why didn't you warn me? Horrible pain.
The first day you stop the medicine, you can have drinks. That's another thing, of course.
And that's the other. So you treat people and you want to do a couple of one says, take it easy. You're going to have to ease yourself back into your normal diet. And second, if you're a drinker, people who consume alcohol while on the metronidazole, the tinidazole, can have this. We call it a disulfiram, but you drink the alcohol. Anything carbonated just doesn't taste right, and then you get this weird, sort of nasty taste in your mouth.
Exactly.
All right. Let's give away a book.
Here.
So I identified 5 individuals who
Cool.
apparently did not get one before. So let's pick a number between 1 and 5. Are you ready, Dickson?
I'm set.
That number is 2.
Hey, number 2.
And, number 2 happens to be
It sounds like Blair.
So Blair, if you have not won one before, a copy of PD6, this will be autographed by Dickson and Daniel.
Right.
Send an email to twip@microbe.tv. If you're in the U.S., that's all you need to do. If you're overseas, I need your phone number as well. And today, since Dickson and Daniel are here, they were able to sign
We are here together.
books. So I will be sending out the ones that are owed way back since last year, November. I'm keeping a list and checking it twice. I will catch up with all of these mailings.
Yeah.
Post haste.
Post-haste.
All right. So let's move on to our paper, which is interesting on a number of levels. First, the title is Glycocalyx Breakdown is associated with severe disease and fatal outcome in Plasmodium falciparum malaria.
Right.
And this is from a number of institutions, including Menzies School of Health Research in Australia, the Lee Kong Chian School of Medicine in Singapore, Tan Tock Seng Hospital in Singapore, Duke University, Papuan Health and Community Development Foundation in Indonesia, the Mimika District Health Authority in Indonesia, the University of Oxford, and the University of Utah. Wow, that is an international group.
Exactly right.
Now,
these are parasitologists without borders.
They're parasitologists without borders.
It's great, right? To see so many people, so many institutions all working together.
Exactly
Fantastic.
right.
And now, the subject, the Glycocalyx, right,
Yeah.
Dickson? We
Yeah.
talked about this on TWiP.
We did.
2 weeks ago.
We actually did in tight junctions also, but in this case, just the glycocalyx is under
And
discussion.
in that case, it was how flaviviruses
That's right.
disrupt the
You
glycocalyx.
can use it as a receptor.
And now it's how malaria parasites disrupt it, right?
Exactly.
Now, Daniel, what is in the blood vessels? What's this glycocalyx, and why is it important?
So we'll give people a visual here. And I've seen some wonderful EM images, electron microscopic images, and it almost looks like a little fur on the edge of the cells. And so if you think in your mind, think of that show where people get in the spaceship, right, and they get injected, like they're miniaturized and get injected into the blood vessels.
Oh, yeah,
And
fantastic
so,
voyage.
fantastic voyage, right?
Well, there's a ride at Disney World where you get injected into a bloodstream, and I hate it because you sit in this thing, it's bumping, and I get so nauseous. I can't stand it.
Oh my gosh! And I bet the glycocalyx is not done justice. But if you could imagine, you're in the spaceship and you're not bouncing around or nauseated. You're just nice, smooth, laminar flow.
Right.
But if you look at the walls, there is this fur. But what it really is, this fur is actually this carbohydrate-rich layer, and it lines. And it has a really important role because it regulates, we say, vascular homeostasis, as opposed to this inflammatory cascade when connection molecules are exposed. So things we talk about, integrins and other molecules that allow for cells and microbes and pathogens to, instead of just flow along, actually bind to and trigger this whole inflammatory cascade. So the glycocalyx is this really important thin fur that coats a normal, healthy, non-inflamed blood vessel.
Endothelium.
And the endothelium, right, is this lining of cells that you're looking at when you're traveling in your laminar flow vessel at Disney, I guess. And what they're bringing up is that when, according to what they're going to present to us, when you disrupt this fur, this carbohydrate-rich lining, you then can expose and trigger this whole inflammatory destructive cascade, which they're going to say is associated with disease severity and death.
Right.
Now, they say that normally the glycocalyx prevents the red blood cells from attaching and sticking.
That's right. And the platelets.
In the blood vessels, correct?
That's right.
Yes. And so when these erythrocytes have malaria inside of them, then it changes their surface, right?
It does.
And then they stick to the glycocalyx.
Indeed.
That's correct?
Yep.
Well, this is correct. And then that sticking can induce changes, right?
Well, yes.
It's interesting to see sticking to the glycocalyx. In a sense, I think of the glycocalyx as sort of protecting and sort of shielding a lot of the attachment molecules.
I see.
So I don't know if they're binding to this so much as when this gets shed and disrupted,
They bind
it
to
exposes
underneath.
Yeah, exposes
Okay.
underneath.
One of the issues
Got
of
it.
this parasite is that it prevents the deformation of red cells. When red cells enter the capillaries, they're too big to go through. They have to actually deform in order to go through the capillary.
Right.
And the reason for that is really obvious because it increases the surface area of the red cell contact with the endothelial cells, and that facilitates gas exchange between the tissue on the other side and the red cells, right? So Plasmodium falciparum, when it infects a red cell, it takes away that ability of the red cell to deform. The other thing it does is from the inside of the parasite, it secretes a histidine-rich protein, which migrates just under the membrane surface of the red cell, and it forms a very highly charged receptor, a non-specific receptor, which it would attach to anything negatively charged, basically. So that's basically the way it holds on to the precapillary venules that lead into the capillary beds and don't allow this parasite to actually go forward. What it does for the parasite, of course, is it drops the oxygen content of the local area because the blood stops flowing. This parasite is a microaerophil. And we didn't learn that until someone came along with a candle jar, that they used to.
Bill Traeger?
Yeah. Yeah. And Jim Jensen. Jim Jensen gave him the idea. He says, have you ever tried to grow these things in a candle jar? And he says, no. He's been working on these chemostats and he had it oxygenated and everything, of course. But the life cycle of the parasite didn't really indicate that. And I'm not saying that Bill Traeger didn't know his stuff. He was an absolute genius with regards to parasitology and malaria in specific. But the moment they changed the growth conditions to a microaerophilic environment, the parasite took off and multiplied inside the red cells in vitro. And this gave them an assay for all kinds of things after that, right? So this is a little background as to why this is a severe disease, because if this happens, of course, in the precapillaries of the brain and the oxygen level goes down, you know that brain tissue requires a high oxygen content. It gets the lion's share of the blood besides the heart when it pumps out of the right side of the heart. So what you've got here is an explanation as to why this becomes a fatal infection. And I loved this paper, by the way, because there were some things in it that I want to ask our physician on call.
I wanted to ask about nitric oxide. So
all right.
This
we primed. Did I write that somewhere?
No. Isn't that induced by tumor necrosis
because that was
factor?
actually that's why I guess I should say followed this line of research. Is back in the 1990s, I actually went out to University of Utah to work with a couple of these authors.
Wow.
So there was Don Granger, there was John Hibbs, there was actually Maureen Hobbs, and Nick Anstey, who's down in Australia. And we were working on trying to understand nitric oxide in malaria. And this paper deals with adults. We were looking at pediatric malaria deaths and seeing this association with nitric oxide. And what do we know about nitric oxide? We know about nitric oxide from an inflammatory point of view, but there was a Nobel Prize for nitric oxide and its role in vascular dilation. So nitric oxide actually plays a not completely understood role, but probably plays two roles. It's probably related to when you have nitric oxide functional, you can dilate, you can modulate the size, but you also can have what we think a more robust immune response to pathogens, including malaria. Right. And what they're talking about here, they're continuing this story, is that when you disrupt the glycocalyx, it falls apart. You're not only disrupting the immune system, but you're also disrupting the vascular ability to respond appropriately to this stress that Dickson is describing.
So they say that it had already been known that when malaria is present, the nitric oxide goes down. Is this produced by the vascular endothelial cells?
So one of the sources is vascular endothelial cells, but it's also produced by some of our immune cells as well.
Macrophages.
Macrophages would be the classic.
Yeah.
But I was led to believe earlier in my life as a teacher that when the parasite induces nitric oxide formation, isn't that what puts the patient to sleep?
I don't think that's true.
So that data has been.
I don't think that data is panned out. Yeah, and it's actually that's interesting. What you're seeing here is actually the people that do worse are the people with the lower nitric oxide levels, right? The people who die, and actually that was one of the things that we sort of discussed a number of years back was, could you use nitric oxide therapeutically? Like where people having trouble because they didn't have, and I think again, you're sort of following the stories, people with the lower nitric oxide bioavailability, and actually here they're specifically looking, or is it more so looking at vascular NO bioavailability.
Vascular. Okay. So on the tissue side of the vascular bed, I was led to believe in the old days, of course, that malaria induces tumor necrosis factor, which then induces nitric oxide formation. on the tissue side,
which we think is part of a good immune response.
We think this is true.
Yeah.
Right. Is that still true?
I think it's still true. But again, and here we are, we're doing the math 20 plus years later, still trying to understand, trying to work out the role of nitric oxide in malaria.
So then I learned
Okay, keep going.
that if you gave a lookalike amino acid to arginine, which is the source of the NO, but without NO, namely aspartic acid, you could wake up patients that were put to sleep by this parasite. And then you could give them oral medication. That was the story that I ended my career on.
Interesting.
And I have no idea of how valid that still is because
now, was this causal? Did this cause your career to end, or it was just the timing
No, my
issue?
career was ended long before that.
You still have a career?
I still have a career, but
You mean your lab shut down?
no, I don't mean. No, he was joking. I followed the literature secondhand, and I think Nicholas White was my source of information on a lot of things, and I believe that I learned that from reading some of his papers.
I should actually. So other studies they've done. There's been times where L-arginine has been looked at and nitric oxide has been looked at. So what they're doing here is they're using a technique called the reactive hyperemic peripheral arterial tonometry.
I want to talk about that too. Where was that work done? Was that done actually in Papua New Guinea or not Papua New Guinea?
Well, so it has to be done there because you're using a finger probe.
Okay.
You have these actual finger probes that, certain company, maybe Altera may produce. I forget which company produced it. But you have finger probes and you actually put them on the finger of people who are ill, right? Some of these people, 3 of them, as we see, ended up dying. And it's actually measuring it's a volume measurement that you do. But, so this isn't a lab assay that you send out for. This is on living patients.
Correct. So then I have this big question for you then. Some of those patients that were severely affected by malaria were treated with intravenous quinine, not intravenous quinidine, intravenous quinine,
right,
which has the ability to induce arrhythmias and to lead to the death of the patient, not related to malaria, but actually to the treatment. So here they have this incredibly sophisticated machine to measure something quite remarkable, and they don't have intravenous quinidine, which is the substitute for quinine. And we've covered this in previous episodes of malaria. Why was that absent from the pharmacopoeia?
I was going to claim that it's not that sophisticated. There really is just a small device that allows you to get this very interesting.
It has a very long
parameter.
name to it. Though.
It does.
The machine that goes.
I think the name is much longer than the actual. Device.
All right, but I was really dismayed by the fact that they didn't have intravenous quinidine and they had to use quinine, which has high risk associated with it. I don't know if that was ever brought out by the reviewers.
Well,
of the paper,
they did have 3 deaths in the severe.
They did,
malaria
but okay. So why did they die?
No, we don't know because some of them got. Most of them got artesunate. So
they did, but that didn't do any good, though, right? Because they died.
Well,
that's
3.
That's an interesting issue. So, what is the mortality in adult severe malaria? Because we talk about there's let's say we'll use rough things. We'll say there's 500,000 people who die of malaria a year. We'll say 90% of those are children, 10% of them are adults. In adults that get severe malaria, the mortality is still 10 to 20%.
Yeah.
And in this study, we actually were seeing about an 8%, so actually slightly lower than expected mortality in the severe malaria cases. But yeah, adults still die. But it's interesting, and I think I've brought up on prior TWiPs, is that I've been in areas of Africa where because your likelihood as an adult of dying of malaria is so low, they don't take it quite as seriously in adults. Right. They view it only as a significant disease in children, which,
that's right.
I know is not quite true. In this area,
they were all the same age, right? Every one of these patients was within 2 years of each other.
Yeah, these are adults, so
they're amazing.
129 adults, and they measure. So they want to know if the glycocalyx is degrading by measuring the products in plasma and urine.
Exactly.
That's pretty nice.
They're looking for byproducts of the breakdown of the glycocalyx.
These include Syndican 1.
Right.
So it sounds like a Cosa Nostra thing.
It does, doesn't it?
I said that last time on Twitter.
Well, that's okay, but it's still valid.
And glycosaminoglycans, GAG.
Right.
And they do some sophisticated mass spectrometry.
They do.
All right, so they find these were higher in severe malaria compared to moderately severe or the controls.
Right. These are all observational.
They're all observational.
So there's no experiments going on here. They're just looking at
They're measuring. They know how serious the malaria is.
Exactly.
And they say, what are the levels here?
That's right.
And then they correlate these levels with parasite biomass.
Yes.
Okay.
Yes.
And basically, they find out that the correlation between severity and the levels of these Glycocalyx breakdown products still hold.
And they have another measure of severity by measuring the histidine-rich protein number 2.
Correct.
In urine, and that is very, very high in patients that are severely affected.
Which you would expect, I guess. Right?
You would, but it's quite amazing that you can get a nice readout like that in urine, right?
In particular, this the biomass levels of parasite correlate with Syndican-1.
This suggests, by the way, there's a kidney dysfunction aspect to this as well, because that protein shouldn't be getting out in the urine.
Yeah. There's another marker, sphingosine-1 phosphate,
right,
which they say mediates the integrity of the glycocalyx, and they see it go down because it's reduced in malaria. With the more severe, that goes down as well.
Exactly.
You look at endothelial activation markers. Daniel was talking about this earlier. Like ICAM-1, selectin, angiopoietin-2, they're elevated in severe compared to moderately severe malaria.
Right.
Which will make sense, right? Because the malaria is just disrupting the glycocalyx. And then the last thing, Dickson, is how about comparing these products with mortality?
Exactly. Right. I mean, the patients that are going to die apparently were throwing out all this into their urine. And you could easily detect it on mass spec. And
it's clearly a marker for severe
a quick test for when someone comes into the emergency room and you don't have a microscope, or you do have a microscope, but it doesn't matter. If you just took the urine and ran it through this test, which could take minutes if you had the machine sitting next to you, you could get an almost instant readout as to whether this patient was severely affected.
Yeah, one of the things that we really like to have access to in, I'll say, places with limited resources are these lateral flow assays, where if you can find something measurable that can help you, you get, let's say you got 100 people come into your clinic a day, right? I think we talked about this in Uganda. And you've got a chunk, let's say 30, 40 people a day. And actually, if you're in the rainy season, it's going to be, close to 100 people a day coming in sick with malaria. And what you're trying to do is figure out, who am I going to give oral artemisinin-based therapy to? Who needs IV artesunate? Right. Who needs to go to the hospital because they're, as we talked about, 10%, 10, 20% that are potentially going to die in this setting? Because we want to recognize those people who are the most at risk and refer them to a higher level of care so that we don't have that mortality rate. So this is interesting stuff, because now that we're seeing these, if you can come up with a cutoff, have them do the urine, just like a pregnancy test, which is a lateral flow assay.
Right.
Have them just detect, it's above such and such, this bar comes across. You set your sensitivity threshold. You could be like, these people are going to need IV, or these people are going to need referral to a higher level of care. And it becomes back negative. You can say, okay, if we have a nice discriminator here, these people we can treat safely in our clinic with oral medication, which, the vast majority of people infected with malaria can be treated that way.
Exactly.
Yeah, they mentioned that it might be a simple assay to measure GAG, for example.
Exactly. So I remember sitting at an American Society for Tropical Medicine and Hygiene annual meeting and hearing Nick White give a series of CPCs, or clinical pathological conferences, where he would have a case and he would give some features of the case, just like we do on our show. Yeah. And then he would ask for guesses, and everybody would guess. And then he would say something interesting, like a lateral correlate. And in the case of severe malaria, he said, we do a quick microscopic smear, stain it with Wright's, not Gamesa, and we look in the neutrophils for malarial pigment. We don't even look for the parasites. We look for the pigment being taken up by neutrophils. And if we see it in the neutrophils, that patient has a 20% parasitemia. I mean, they're really infected. And those are the ones that we really have to worry about. And so that's their triage
Yeah.
I don't think they do that anymore. I think they're probably into this stuff now with glycocalyx disruption, et cetera. But in the old days, that was good enough.
You know, I mean, in the field, we're still, and it's very quick, actually, to go ahead and do a smear, relatively quick to do a smear. To get a sense of levels of parasitemia, and that's actually one of the severity scores. Let's say above 10%, you say, okay, this is severe. But they talk here in their discussion about a colorimetric, where just like on a urine, it could be a light green versus a dark green, and actually not just a black and white, but you can get some sort of a gradation of severity based upon a colorimetric urine dipstick, which would be I think it's a fantastic idea.
I agree.
They also say that you might think about repairing the glycocalyx with drugs, right? To use as an adjunctive therapy for people with severe malaria. What do you think of that, Dickson? Repair the glycocalyx. Give people drugs. I don't know what you would use to do that.
Are there drugs that can actually do that?
It says here, in animals, several agents can attenuate or repair glycocalyx damage in animals.
That's remarkable if that's true, because that might take some time, however, and this parasite is probably quicker than your therapies.
No, but I like that, because that may even move, to all forms of severe infection, or what people like to call sepsis. Is that endothelial dysfunction is kind of a catchphrase in the world of severe infections. And if you could do something not just for malaria, you're not just treating one pathogen, but you're treating the immune system, basically broad implications.
Well, Dickson, the flavivirus paper where it damages the glycocalyx, you could use the same drug for that.
Yeah, well, that was tight junctions also, though, and I'm not sure that those are two of the same things. I think they might be different.
Could be.
Related, but different.
Very interesting.
But all very interesting, is right.
Yeah, I think the virus is going to have trouble getting to the tight junctions if you have an intact glycocalyx border.
I mean, in that case, that paper, they both messes the glycocalyx and then loosens the tight junctions as well, so it could get through.
That's it.
Right, it has to
get
through
the fur, and then it gets into the tight junctions.
Right. Then it gets into the tissue from that blood vessel, right? It has to pass into the tissue to be able to replicate there.
Indeed.
So if you could repair the glycocalyx, maybe you prevent virus from getting into the tissue. Who knows? Who knows? Very interesting.
We need a supplement, an herbal supplement that maintains your glycocalyx.
Herbal.
Indeed.
Exactly.
Lactobacillus reuteri. All right. Anything else, Daniel, before we leave?
No, I think that's
good. All right. Dickson, do you have a hero today?
I do. I'm having difficulties getting online. I don't have to get online for this one. I don't, because I can give you personal recounting of this person's life. The name of our honoree today is Dame Bridget Ogilvie. And Bridget Ogilvie and I first met at my first international conference in Munich back in 1973, as I recall. It was a long time ago. It's while she began her career at the Medical Research Institute in London. And she was there as a parasitologist. She originally was born in, everybody was originally born somewhere. So she was born in Australia. Grew up in Australia. Went to school. We can edit this. She grew up in Australia and was interested in veterinary medicine at one point in her life, and then got interested in parasites, and then got so completely wrapped up in the biology of worms, basically, that she devoted most of her early career to studying them and was trying to develop an animal model for hookworm when I met her. She was busy working with hamsters, trying to adapt human hookworm to hamsters. And I don't think she succeeded, but she certainly gave it the old college try. She told me in a personal anecdote that when she first announced to her mother that she was going to devote the rest of her life to working on worms, her mother replied, "Bridget, when I see a worm, I step on it." I'll never forget that quote, because these are not that kind of worms. In fact, for hookworm, you better not step on it, because that's the way you'll acquire it.
If you have a shoe on, that's okay.
This is true. She rose in the ranks of British researchers that were were passionate about parasitic diseases and developed a sterling career at the MRI, but also became a politician of sorts, was very interested in funding and very interested in distribution of wealth, which had something to do with the prevalence of these infections rather than some trendy medical issue of like personalized medicine or something like this. And she joined the board of trustees for the Wellcome Trust and eventually ended up heading the Wellcome Trust to show you what kind of influence she had throughout the British Isle, throughout the British Empire, as it were, the failed empire, but nonetheless, a lot of people from Canada, Australia, India, and places like that would apply through the Wellcome Trust for research funds, and she was very sensitive to that and a very savvy person when it came to who deserved more than just passing attention to their research, and launched the careers of many people throughout the British Commonwealth, and was knighted. She became a dame. Mm-hmm. And she was a very good friend of another person that I would love to put to our book eventually, Lawson Soulsby. Lawson Soulsby, Sir Lawson Soulsby, he was actually the chairman of the parasitology department at the University of Pennsylvania for many years, and I got to know him through local meetings. And he and Bridget Ogilvie, once he went back to England to become, I believe, chancellor of the veterinary school at Cambridge, teamed up with Bridget in order to identify talented people that deserved early career encouragement through funding for their research. And so she's been an enormous influence in the world of parasitic disease research and deserves the status of superhero, I would say. She wears a cape, and she's got a
cape?
She's got a P right on the front of her sweater that stands for parasite, and she's out to kill them all.
She's 80 years old.
Yep.
Still around, living in Australia.
She is. She
maybe
retired.
She lived in the UK. She was born in Australia.
Yeah, she was born in Australia.
So do you know, since she retired, she has turned to public engagement with science and science education.
Yeah,
she's a trustee of the Science Museum and chair of the AstraZeneca Science Teaching Trust.
Look at that.
Maybe she'll give us some money.
This was not a plug in that sense, but I hope she listens to this podcast and remembers some of the wonderful times that we had together when I first discovered Europe through this meeting that I went to in Munich.
He's the first hero that you've known personally?
No, I knew some others. I knew Bill Campbell very well too.
Was he a hero already?
Sure, we've already talked about him.
Okay,
yeah, we have.
I know that you knew Bill.
But Bridget is. She is a living legend, basically. People, when they mention her name, you hear heralded angels sing in the background and trumpets blare. That's right, exactly right. And well-deserved, well-deserved. She's essentially devoted her entire life to this subject.
Okay. Thank you, Dickson.
You're welcome.
And now, sharpen your pencils.
Exactly.
It's time for a new case.
Oh.
Get out that thinking cap.
Pencil sharpening is a wonderful exercise.
All right. So this is a woman who is, I will say, approximately 30 years old, and she has this story of traveling to. She's done a little bit of traveling, but her most recent trip was to the Dominican Republic, where she went down to the Punta Cana, the tourist part of the Dominican Republic, and she returned and she went to see her primary care doctor for her yearly physical. And she saw her primary care doctor, who asked her about her chronic constipation. And she said, I know for many years you've been seeing me. You've always had your chronic constipation. I've been giving you advice over time. How are you doing? And she said, I actually don't have chronic constipation. I now have normal, regular bowel habits. I'm actually doing quite well. And so the primary care doctor asked her a little bit more, and, took a travel history. Have you been anywhere? Have you done any travel? And she said, well, I did go to Punta Cana. And actually, now that you mention it, it was a few weeks after returning that I noticed that I now have normal bowel movements, no issues. I don't take anything. everything is good. Now, the primary care doctor was intrigued. So the primary...
Well, he should have been.
She should have been. And she sent off some tests on this woman and got a result back. And the result was that there was Entamoeba hartmanni isolated in the stool. Entamoeba hartmanni. Okay, so...
That reminds me of Mary Hartman.
That's an older show, but yes, I would agree with you.
Okay. Entamoeba hartmanni, okay.
And hartmanni.
In the stool, right?
Into the stool. And I'm going to leave you there, and we're going to address a bunch of questions next time. So what should the primary care doctor have done? What might the primary care doctor have done? And what might be the consequences of what happened?
The consequences of treatment or infection?
Well, either way, people can just sort of. I'm gonna leave people here. There's more to the story that we will unveil next time.
Tune in next week, folks, and you will.
and when she went to him, she felt fine, right?
Actually, it was as I mentioned. They showed up for their normal physical, and it came up because this is a person who had since they were, as this woman told me, since she was a teenager, she has had chronic issues with constipation.
Wow.
What does that
and
mean
now she shows up at the doctor.
How would you interpret that if someone said, Doc, I've had some chronic constipation? What was your take on that?
Well, I asked her a little bit about, you mentioned constipation. Well, when did you first know? So apparently as a child, her parents took her to the doctor because she was having issues with, becoming constipated, not having normal bowels.
1 day, 2 day, 5 days.
Oh, so that's a good one.
For how long did she
what is the normal range,
exactly,
right?
Exactly.
And there used to be this idea, we're just going to talk a lot about constipation now. There used to be this idea when a lot of these adults who now are in the 80s and 90s, and the idea was you need to have a bowel movement every day. You have to. And if you don't, as my grandmother once said, you'll get sick because no one wants a bad tenant. And so people would actually take agents. And my great grandmother actually had cataract surgery. This is many, many years ago, and was given some pain medicines afterwards. And she then the next morning was not having her normal.
Got it.
And she strained so hard because she had to.
Oh dear.
Because if you don't have a bowel movement every day, you will become ill.
Dear.
That she actually she had a lens put in during the surgery,
right?
And strained so hard that the lens popped out.
Oh my gosh!
Gee whiz!
So there is this obsession at one point in medicine that you have to have a bowel movement every single day, no matter. But a normal, variation in a human being might be 3 times a day, up to once a week, and it's very diet dependent.
Up to once a week.
And it's very diet dependent, and
Wow.
it also is not only diet dependent, but there's a variation in genetics. Certain people will have 3 bowel movements a day. Let's say meat eaters who eat a lot of meat.
My dogs have 3 bowel movements a day.
Exactly. Carnivores tend to have more bowel movements per day. Herbivores tend to have less. I think we mentioned at one point the sloth, who has a bowel movement about every 8 days, and apparently triggered by rainfall.
That's remarkable.
8 days.
Yes.
I didn't know
but triggered by rainfall.
Wow.
And apparently there's a selective thing where, the sloths, part of their way of keeping safe is by moving very, very slowly.
Yes.
But if the feces were falling down, that might attract a predator. So apparently there is something where rainfall is associated with when they defecate.
Dickson, can we know your bowel frequency?
I have
just
some
kidding.
personal stories along these lines. No, I'm serious. No, we're not going to get personal, but I'm going to tell you that every time I take a long... No, listen.
I don't want to.
Listen and learn.
Okay.
I know. I see you going to the bathroom.
No, that's not for that reason, though. That's a number. Forget about that. When I take international flights, invariably I dehydrate. And dehydration leads to constipation. So I now travel with these interesting fruit products, plums, which are air dried into the form of pitted prunes.
Yeah.
And pitted prunes are the salvation of humanity.
Those are wonderful. I love them.
They are fabulous. And if if I'm regular in my dosage of prunes, the long-distance flights don't matter
That's
at all.
interesting, because I get dehydrated, too, because I can tell I swell.
That's right, exactly.
But it doesn't constipate me. It's curious.
And then, when I'm abroad and I'm sitting in a lovely restaurant in France or Italy or someplace, and I've had a wonderful meal, and I've had another wonderful meal, and then I've had another wonderful. I said, when the hell is this going to happen? And it's sometimes it's been a problem.
But you're not a once a week person, are you?
No.
I've never known anyone.
No, I've gone from.
Frankly, I don't really discuss it with people.
But everybody.
So I don't know.
These are not people. These are fans. They deserve to know. And I used to be a doctor would ask, have you had any difficulties with regards to defecation? And people with bowel tumors, of course, have difficulties with defecation and that sort of thing. So your gut times are slow. I used to be, Mussolini would have been proud of me because you could time the trains to my bowel movement every single morning at a certain time. Mm-hmm. That was the time. That's changed as I've aged. That has changed.
Interesting.
Normal has changed.
It's interesting. When I go for my annual checkup, my doctor doesn't ask me anything about bowel frequency. Should that be part of the question, you think?
It should be.
Actually, that is one of the, well, for you're getting your frequent colonoscopy, so maybe they feel like that's even more exacting than a history question. But that's one of the warning signs for colon cancers is change in frequency, change in caliber.
That's right.
Interesting. Well, this is an interesting case. It has prompted a nice conversation.
We will discuss even more.
Last time we had diarrhea. Now, I have a feeling Kevin is going to do something interesting with this.
Yes.
This is called The Truth Will Out.
I want to just read a couple of emails here before we end up. One is from Charlotte, who writes, Dear Twipsters, thank you for keeping me entertained while on my sick bed. 4 months later, still recovering from a prolapsed disc L5 and separated from reaching my scientific dreams, PhD and beyond, but you've raised a smile from me.
Oh, you have my deepest empathy.
Charlotte is in London. Kevin writes, now, Kevin had a submission for the elephantiasis case, which was last time, but we never got it.
We never got it.
And he says, not sure why my submission did not get received, but I'm sending it along so that perhaps it can be put into show notes. Check out my elephantiasis anecdote under a terminal curiosity. But I want to just read some of the initial things here. He says, I begin with a quote from the English surgeon Percival Pott, who many will remember elucidated the nature of the soot ulcer, scrotal carcinoma of chimney sweeps, one of the first occupational illnesses to be clearly described. Pott also described tuberculosis, spondylitis, and developed many surgical techniques, among those being correction of hydrocele. A hydrocele is so irksome a disease to the indigent and laborious, furnishes even the easy and opulent with such disagreeable ideas and apprehension, and is to all who are afflicted with it so troublesome and inconvenient that every rational attempt toward relieving mankind from such an evil will, I make no doubt, be favorably received. And he goes on to say that difficulty is not making the diagnosis, but grasping the enormity and complexity of the overall problem. WHO estimates 40 million people are afflicted with some manifestation of lymphatic filariasis every year. It's a lot. And,
it is.
Goes on to talk more about that in treatment. So here is the endnotes and a terminal curiosity. These all will be in the show notes for this week. Let's see.
I feel bad. What a lot of work he put in to be missed out.
He writes wonderful medical historical pieces, and I think that perhaps we should put his collection together sometime. And
by the way, he shouldn't publish it and make money from it. Podoconiosis. I was fascinated to learn about this condition. Non-filarial elephantiasis. That's interesting. I didn't know that. Did you? Any of you know that? Non-filarial elephantiasis.
Where did you read that?
It's always near the end.
Actually, we had someone write in about that last time, so a certain...
All right, and it's all the way at the end, Dickson. And a terminal curiosity. Several years ago, I visited a bedbound woman who weighed well over 500 pounds. In addition to the burdens of obesity, she was afflicted with massive bilateral lymphedema of the legs. This American woman had never traveled outside the U.S. She had a condition known as elephantiasis nostrus verrucosa. This entity is reviewed by Castellani, a famous tropical medicine researcher who authored the 1913 note on copra itch referenced in TWiP 157. This is the only time I had encountered anything like the appalling photograph seen in tropical medicine textbooks. During our visit, I mentioned that her condition was known as elephantiasis nostrus. The patient immediately became very distressed by the association of her lamentable state with elephants. It took my best medical casuistry to backpedal out of this morass, and the whole episode taught me the profound subjectivity and emotional content of medical language as interpreted by patients. WHO published guidelines concerning the naming of the disease in 2015. Press predictably branded the WHO initiative as a species of political correctness and reported the story in a slightly snide or frivolous way. As the above anecdote shows, a name can have profound emotional impact. Naming diseases after geographic locations can even have economic consequences.
Oh, no question about it. No.
This topic stimulated me to recall the many medical terms that are named after animals, many of which would probably be very distressing to patients. Fortunately, many of these terms are being replaced by more accurate descriptors, and these include rodent ulcer, basal cell carcinoma, mouse cough, facial appearance and sclerodema, pig bell pigeon, English term for post-starvation gastroenteritis, lupus pernio lupus, bird flu, swine flu, ichthyosis, who wants to be compared to a fish, moth-eaten, alopecia, monkeypox, mad cow, leonine, buffalo hump, butterfly rash, simian crease. Monkey analogies are to be universally avoided. Raccoon sign, phocomelia, bulimia, equinovarus deformity, elephant man syndrome, spider angioma. And for completeness, let us mention anatomic terms with animal associations: hippocampus, pes anserinus, vermiform appendix.
It's actually, some of it, it's disturbing. If you think about the story of the original, quote unquote, elephant man, which was a case of, I believe, neurofibromatosis.
Right.
The treating physician's theory on why this young man had elephantiasis. Do you guys know the story? The physician diagnosis was that the mother was frightened by the sight of an elephant in a traveling circus, and that trauma occurred during the pregnancy, which led to the child coming out with the
interesting.
Really, really disturbing.
But I think he's got a good point here. Many people would be repulsed by
the doctors don't usually say these things in front of their patients, though. They usually just talk among themselves, as it were. It reminds me, though, of a Gary Larson cartoon, which shows two elephants at a clinic, and one of them has a very small front leg.
Yeah.
And the elephant doctor comes out and says, "I'm sorry I have to tell you this, but you've got a case of human analysis."
Very good. Very good.
Like a little human leg there. I think I've seen that one.
Yeah.
But no, I think this is a point well taken. The terms do, like, words matter.
They do. Of course they do. And if people think you're degrading them by simply reducing them to a series of derogatory terms, that's awful.
Well, I'd never thought of it in this way, but
awful.
Makes a lot of sense, right?
Yeah.
And even something as innocuous as monkeypox or bird flu or swine flu.
Why is it?
Do you have swine?
I mean, monkeypox, I thought it came from monkeys. I think that
you get it as a
but that doesn't mean you look like a monkey because you caught it.
You can imagine someone will think, why do I have this disease of monkeys? Could be offensive. It's not something you have to worry about here in the U.S. We don't see much monkeypox.
No, we don't. Although in Minnesota.
Well, anyway, I don't have to worry because I am not a physician.
Yeah, actually, it reminded me of a case. Actually, this was in Utah. We had a medical student who had some social challenges, and we were taking care of a patient who was convinced that her malady was due to parasites wandering about her abdomen. And this patient underwent a CAT scan. And the CAT scan showed some diverticulosis. And we went in to explain to the patient that we had done the CAT scan and we didn't find anything that was concerning.
Yeah.
And as we're explaining this, the medical student said to the patient, "Yep, all we saw were a bunch of ticks." Which is the slang, I guess, for divertics.
Oh, dear.
And the ticks on it just erupted into
a bunch of ticks. Oh, Jesus.
So, yes.
So, yes, that's what's causing my problem.
Yes. That was, that didn't go well.
So, to get back to the beginning of TWiP, the song is endless, but the malady lingers on. So, Harry Ginsberg used to use that to describe herpes herpes viruses. Right?
Very interesting. Very interesting.
So, because they go on and on and on.
Right.
And so does TWiP. We go on and on and on. We will go on until each of us is dust. Isn't that poetic?
Blowing in the wind.
You can, we'd like you to subscribe to TWiP. It's free. And if you play the podcast on your phone or tablet, there's an app you use, and usually you can subscribe. And we like that because it tells us how many people are listening. And we're very lucky to have lots of you listening. And if new ones join us, just subscribe. That would be great. And if you love what we do, please consider contributions at microbe.tv/contribute. And of course, you can take a guess at our latest case, and you can enter to win a free copy of PD6, autographed by Dickson and Daniel. All you have to do is send in a guess to twip@microbe.tv, and of course, you could also send us emails. Daniel Griffin is at Columbia University Irving Medical Center and parasiteswithoutborders.com. Thanks, Daniel. Good to see you.
Oh, a pleasure as always.
Dixon Despommier is at Racaniello.org and thelivingriver.org. Thank you, Dickson.
Had a great time.
I always see you.
You do.
But it's still good to see you.
It's nice. We're comfortable in each other's presence.
It was very weird last time not seeing each other.
Oh, that was bizarre, and especially since I had the sound turned on to my computer sound and my headset. So you got some feedback through that, weird. Which was not so good.
Oh, well.
Oh, I got to listen to that.
Well, I fixed it.
It's all been fixed.
You won't hear anything.
Okay.
Fixed.
Then I don't even have to bother.
I'm Vincent Racaniello. You can find me at virology.ws. Thanks to Ronald Jenkins for his music and ASM for their support. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.
Oh, that was beautiful.
You
well,
see,
we're
we
together.
Can,
that was beautiful.
We can see each other.
You could lead it like music, and it just flows across
You're very concerned about the
synchrony,
the nice synchrony at the end. Aren't
the
you?
synchrony. I am because I think we should all be in sync. That is exactly right. And this was perfect. If you could just use that all the time, this would be great.